Good afternoon, everyone. Thank you for joining in from whichever part of the world you're joining. Good afternoon, good evening, good morning. So, we will wait for a few minutes for everybody to settle down and then we shall begin. Thank you so much for your patience. We shall wait for a couple of minutes more because I think we are getting messages that people are still joining in. So, we shall wait. I think a couple of minutes more and then we can begin. We have our speakers already joined in. So I guess another few minutes and we should be ready to start. Once again, thank you everybody so much for your patience. I guess today seems to be like a really popular and interesting topic because we are still constantly getting messages another 2 minutes and we'll join in. So another, I would say another couple of minutes and we are on. All right, then. I think without any further delay, let's get started with our session today. So, good afternoon, good morning from wherever you're joining in, and a very, very warm welcome to you all. Thank you for taking out time to join us today. My name is Nancy Dugal, and I will be your host for today's webinar on cost containment in health insurance. On behalf of Prospera Global, it is my pleasure to welcome each one of you. We are delighted to see professionals from across the healthcare insurance industry joining us for what promises to be an engaging and an insightful session today. As healthcare costs continue to arise across the globe, cost containment has become one of the most important priorities for insurers, healthcare providers, employers, and assistance companies alike. The challenge today is not simply about reducing costs, it's about doing so while maintaining quality of care, ensuring positive patient outcomes, and creating a sustainable healthcare ecosystem. Today's session is designed to explore exactly that. We will discuss the practical strategies for effective cost containment, stronger claim governance, fraud prevention, efficient claims management, and the role of collaboration between insurers, TPAs, providers, and assistance companies in delivering sustainable health insurance solutions. At Prospera Global Health, we strongly believe that sharing knowledge and industry best practice is essential to driving meaningful change. Through this webinar series, our goal is to bring together experienced professionals who can share real world insights and practical approaches that benefit the wider healthcare community. If you have any questions during the session, please feel free to put them in the chat box and we shall address them in the end of the session during our question and answer round. We are especially fortunate to have some fantastic speakers with us today. To introduce them and take this session forward, I will now invite and hand over the session to my colleague, Mr. Ankit. Ankit, over to you and thank you so much. And welcome once again, everyone.
Thank you, Nancy, and a warm welcome to everyone joining us today. Well, I will begin by saying this. I see this every single day in my own role. As a part of medical assistance company that works alongside insurers and TPAs, every case that lands on our desk is a balancing act, doing what is clinically right for the member while keeping costs sustainable for the payer. And if there is one thing in my experience which has taught me, it's that real cost containment doesn't come from saying no more often. It comes from getting it right the first time, the right provider, the right setting, the right intervention at the right cost. When that happens, the member gets better care and the payer saves the money. I mean, that's not a trade off, but that's good operations. And that's exactly what we will explore over the next hour today, how innovation from medical audits and structured care coordination to AI-driven insights is transforming the way health insurance claims are managed. And to help us unpack all of this, we have three outstanding panelists who bring deep, hands-on experience from across the UAE health insurance ecosystem. Let me introduce them to you. Our first panelist is Dr. Mohammad Saqib Iqbal, who is the Senior Manager, Pre-Authorization Medical and Life Claims at Sukoon Insurance. Do we have Dr. Saqib? Chetan, you can put them on the screen so that our audience can see. Dr. Saqib is a physician with 14 years of experience spanning medical pre-authorization, claims, audit, and underwriting. As a senior manager pre-authorization, he oversees the outpatient, inpatient, pharmacy, medical call center, and case management functions. He holds multiple industry certifications, including LOMA and the Managed Healthcare Professional Designation, AHIP, and brings deep expertise in managed care and health insurance operations. Please join me in welcoming Dr. Saqib Iqbal. Thank you, Dr. Saqib, to join.
Thank you. Thank you.
My pleasure. And our second panelist is Dr. Arjun Manivanan. He is the Medical Claims Manager, Employee Benefits, Individual Health, Group Health, and Life at United Fidelity Insurance. We welcome on board Dr. Arjun.
Thank you. Thank you.
You're welcome. Few lines about Dr. Arjun. So Dr. Arjun is a physician and healthcare insurance leader who has held key positions at DHA, that is Dubai Health Authority, Nas Neuron, Daman, and Fidelity United, spanning clinical documentation, high-risk inpatient authorization, enterprise clinical care innovation, and how medical claims and fraud analytics leadership. Across these roles, he has driven the shift from manual claim processing to automation and data-driven governance, including host-to-host payment automation, AI-enabled denial and fraud detection, and predictive patient risk satisfaction. His blend of clinical expertise and operational leadership across the UAE's largest payer, TPA, and health authority makes him a distinctive voice in healthcare insurance transformation. It's a pleasure to have you on board, Dr. Arjun. And last but not the least, we have our very own Dr. Geeta Sadana, who is the Director, Medical Claims Audit and Training at Prospera Global. Dr. Geeta comes with more than 23 years of experience in the industry and with spending 14 years in UAE insurance market. She is known for her calm, nurturing personality and her ability to make people feel supported and at ease. She brings clarity and structure to complex medical and insurance conversations. It's always a pleasure to have you, Dr. Geeta, with us.
Thank you
I
so much.
think we will. You're welcome. You're welcome. I think we will move on now. All right. Let's start, Dr. Geeta. Over to you. Oh, I'm so sorry. What is? I think this is by mistake. My team has put up a snapshot. I'm so sorry about that. But since we are discussing the same topic, I think it would be relevant for us to have a quick look at it. So basically, it is the cost savings which we have done for our insurance partners and the TPAs we work with for home country, which is 1.67 million dirhams in total for 5 months in 2026. And I just don't want to let my team down, so I'm just quickly reading it out. We have 4.8 star rating as well from our customer satisfaction. So it goes hand in hand, but also it is a very tedious task, and we only know how we manage those numbers. So I'm sure our panelists will be will be able to openly discuss how we manage such critical situations. Sorry about that. Over to you, Dr. Geeta. Yeah.
Dr. Geeta, I think you're on mute.
I'm really sorry for that. Really sorry. So I was actually thanking Ankit for that wonderful introduction. And I really hope I can live up to those kind words what Ankit has mentioned. And yes, it's truly a pleasure to be here. And I'm myself really excited to be moderating today's discussion. See, actually, when I heard the topic, it's cost containment in health insurance, I was really excited because it's one of those subjects that never goes out of relevance. As Nancy had mentioned initially, it matters to every stakeholder in the healthcare ecosystem. Let it be patients, healthcare providers, hospitals, employers, TPAs, healthcare assistance companies, because all of us have a role in delivering quality care while ensuring healthcare remains sustainable. And for insurers in particular, the challenge is especially significant because their goal is to ensure that members receive the best possible treatment and benefits under their policy terms, while at the same time, the claim cost is managed so that they can maintain healthy loss ratios and ensure a long term sustainability. Now, achieving this balance is what makes cost containment such an important and fascinating topic. And it's something, even me for that matter, I've been always keenly interested in. And I'm sure Dr. Arjun and Dr. Saqib will share valuable insights and practical strategies from their own experiences. So, without keeping our audience waiting any longer, I will get started. So, Dr. Arjun, my first question is for you. See, we all know that home country treatment can be attractive for insurers and employers, especially for the planned surgeries and high cost treatments. But member trust remains the key to success for this. Now, in which type of cases does home country treatment make the strongest business and clinical sense? And what governance is required to make sure that member does not feel they are being pushed to a cost effective or you can say a cheaper option?
Thank you, Doctor. So I hope I'm audible. And that's an amazing question, definitely. And I would touch base the question by parts of it. Definitely honestly speaking, cost containment is not achieved simply by moving a patient to a better cost-effective geography, and that's not how it works, honestly speaking. Especially when you take case management or a care journey or care coordination, the elements of it comes as a clinical merit of the claim. So as insurers, we ought to pay for the claim which is justified and which is aligned with the good clinical practice, right? So when it comes to home country treatment, this is two benefits that you by default acquire. So yes, as I said, definitive management plan, which is aligned with good clinical practice. Again, good clinical practice means it's tested, proven, supported by multiple clinical guidelines, helps it as a very good option. For example, simply the difference that happens in home country treatment is that you have a multidisciplinary approach. Uh, when you simply go to neurology for a spine, let's say you have a back pain issue and then you have some disc issues, and the surgeon would simply say, let's go for surgery. Now, it's a single surgeon giving an opinion based on his experience and the clinical literatures that supports it. But at the same time, when you have a multidisciplinary approach, let's say you have a pain management specialist, a physiotherapist, and a rehabilitation team overlooking the same case, along with the neurologist or a neurosurgeon, you start looking at you simply open your windows to multiple different other options. So again, as I always say, for any given treatment, there's multiple treatment approaches. It is very difficult to say which one is best. You can really argue that this is good and that is good. It really comes down to the setting where the multidisciplinary team comes together and says, no, this is the best option. Mutually agreeing, yes, with the plus and minus, risk versus benefit. Yes, let's go for this. So at this time, most cases we have seen that you either change the approach of treatment or you even defer the surgery, going for other care pathways, which on the merit itself gives cost saving. So yes, the whole approach for the home country is to really rely on a tertiary care system with a multidisciplinary approach. That's one thing which I think in the previous presentations also the team had rightly pointed out. But the most important thing is the cultural connection, which gives the benefit of trust for the patient. This simply means it's very much seen in the expat population in UAE, because UAE has a huge variety of expat population. So let's say an example or a scenario where you have a state-of-the-art facility and a Hall of Fame physician who is French, and then you have a patient who is Indian or very much Indian. Now, what would be the aspects of patient's comfort with this physician? Because obviously the most important factors, which is the communication, will be impacted, or how I would explain my symptoms and conditions. Because as standard clinical practice, we always say that the bedside examination is which is very important, and it goes the same with outpatient settings. How much with the clarity a patient can describe his condition, symptoms, pains, a physician can take a better decision on what would be the best treatment plan, right? So really, a cultural bond is very important. And so the same patient, Indian patient visiting a French physician visits an Indian physician, I would never say that one physician is better over the other. Everyone is unique in their own expertise. We all go with the intention of good clinical practice, and our intention is simply to treat the patient for a pain-free tomorrow. So really, the bond or the trust that the Indian physician develops with an Indian patient, and having said that, it goes the same for a German patient or a Pakistani patient or any other nationality, would be that they create a cultural connection bond. And the same goes with UAE as well. Let's take an example of Rashid Hospital. You would generally see an Arabic crowd, and you'll also, on the contrary, see a physician or a clinician crowd who are also from the Arabic origin, so from the GCC and the local country as well. So this all simply means that patient comfort, or patients become very comfortable going to a culturally similar clinic, a clinician coming from a culturally similar region, right? This has a huge impact in terms of the care journey itself. Now let's come to the portion of care journey. Let's say if I go to India, I know the it's a family physician, and I'm able to communicate. I get multidisciplinary care. I get more clarity on my condition and a more better clarity on the treatment. And thereafter, I understand what I need to look after for recovery. So it's not really that I did a surgery and everything is fine. Now the recovery portion is also important, and for any treatment or to fight a disease, it's efforts of a clinician and the patient. If the patient doesn't fight equally with the clinician to get the or to overcome the disease, it's not going to work, right? So definitely, it's very important that the patient is also well educated and is part of this care journey. This really happens when you have a cultural bonding. So cultural bonding has a lot of benefits, and this becomes a very important goal. So yes, we might see from one perspective that you're moving the patient to a cost benefit geography, but at the same time you're also moving patient to a better environment which the patient becomes comfortable. They have the family support and a change in willingness and change in approach, which helps a lot in recovery. So it's not always just the treatment element of it. There's a lot of other elements that come to it, and this fulfills the ecosystem of recovery itself. So really coming down, again, we wouldn't say that we are sending you somewhere because it's cost effective, but it's really because of a choice based clinical pathway, without compromise, with a better approach. To be honest, these hospitals equally have competed, and they have become state of the art facilities. So what you see here in UAE or the other countries, it's almost state of the art. And again, you have probably more robotic hospital surgeries happening in India and other countries as well. So yes, it is very sustainable. From the clinical governance fact, I would simply put it this way: if you are able to answer all the patient's questions, which includes travel fitness assessment, what being transparent on the consent with the patient, giving them a preferred case manager to coordinate their whole journey, and most importantly, supporting them and clarifying to them how will be the post-treatment continuity care and recovery. This simply fulfills all the aspects of governance. So there's nothing more to the governance part of it. So really, as long as you have a triple benefit, which is clinically safe care, obviously a lower avoidable cost, and a better member, comfortable, culturally well equipped and bonded journey, it really becomes a more efficient and a fruitful pathway for the member. So it's all about the care journey itself altogether.
Thank you. Thank you so much, Dr. Arjun, for explaining it so beautifully. It was really very well explained. But I think we would all like to know what are the few conditions, few surgeries, elective ones that you think can be sent to home country for the treatment?
Definitely, Doctor.
Yeah.
So yes, definitely autoimmune diseases, which and cancer treatment. These are two conditions which are very important and newly and new fields, which is very heavy on R&D. But it's also those fields which we consider as uncharted territories. It's not explored to the extent which other surgeries are. But equally, having said that, is neurosurgery, because it includes three phases. One is diagnosis, treatment, and post-treatment recovery. Equally is yes, you have neurosurgery, then you have complicated surgeries, high-cost treatments, and autoimmune diseases, of course, because then again you go into a combination use of biologics and other treatment methods, and definitely you will have an window open to yourself to see what are the options other than the one that you have been advised by a single physician.
Thank you. Thank you so much, Dr. Arjun. It was really insightful. Okay, now coming to you, Dr. Sakib, because you are in authorization, and so the question is revolving around the pre-authorization part. See, we all know that pre-authorization is seen as a cost control gate, because once the approval is given, we know we have to abide by the amounts that we have already considered, the codes we have already considered, and it's also a clinical risk checkpoint. So when a high value admission or surgery request comes in, what are the first warning signs that tell you that this case actually needs a deeper medical review before I authorize it, like in terms of, we can say, clinical indication, length of stay, investigation, provider history, package, and the treatment timing.
Uh, Thank you, Dr. Geeta. Thank you, Ankit. Thank you, Nancy, for giving me the opportunity to share my experience and perspective on the cost optimization, which is actually currently one of the most important hot topic usually everywhere in TPA, insurance companies, wherever we go. And the question which you are asking regarding the pre-authorization, like how often we seen as a cost control gate. Now I'll directly come to my point of view. For me, the pre-authorization and the cost containment. Cost containment is only a unit of pre-authorization. We often view this pre-authorization as a cost control mechanism, but actually it's not a cost control mechanism only. The first responsibility of a pre-authorization is to validate the medical necessity and to ensure the patient is getting the right care, and the provider is providing the right care, right setting, and right time on the right time. Now, if your question is how a high value admission or high value surgery, when it comes, what will be the red flags? See, the red flags whenever there is a high value admission is coming, so we need to identify first, like, okay, what kind of what is the admission, what is the diagnosis. The first of all, we need to look into the diagnosis and the clinical indication, what type of clinical indication is being provided, if diagnosis is adequately justifying the requested admission or not. Because if diagnosis is not even justifying the admission, why to proceed for that? If whatever the medical documentation, medical presentations are being provided to us, like for review, whether the clinical, whether these there is a clinical stability is available, which is requesting for the prolonged admission, when the and if the patient can be managed through the outpatient setting, because we are receiving a request for the inpatient hospitalization, but whether the patient has already received all the outpatient care earlier or not. So, and then what are the requests we received? 1 day admission, 5 days admission. What is the length of stay of this admission? Whether the length of day admission is as per the evidence-based medicine, as per the clinical presentation, whether it is really needed or not. So, what kind of investigations patient has been carried out, like throughout, be it outpatient, be it inpatient? Because I'm just talking about for accumulatively, because outpatient settings should be there also before jumping into the high cost admission or any surgery. And then we need to validate the what kind of conservative management has been done, and whether all the standard treatment care options have been exhausted or not. And then we need to understand what type of provider utilization is there, like if repetitive investigations have been carried out during the admission, say for example multiple MRIs, multiple labs, like they are repeating labs are being done, and the treatment which has been provided to the patient, whether those treatment was provided on time or not. So in my experience, if you will go, the red flag is not only the cost itself, it is between the clinical, it is between to provide the clinical care in the right time, all the right services, and whether those are in line with the evidence-based medicine. If we will look into the whole picture, we can maintain our cost by itself, rather than to jump only to cut down the admission. So my experience, the red flag is not the cost itself, whether whether it is clearly the admission is clearly supported by the clinical assessments, and if the part is not clear for the admission, so we need to dig down more on the medical details.
Thank you. Thank you so much, Dr. Sakib. And again, going back to the provider history, because see, especially in UAE, let's talk about, or it can be anywhere. Like, have you ever come across sometimes for like a daycare procedures, like endoscopies for that matter, like colonoscopy, gastroscopy? If that is like a pattern being followed by a particular provider, or let's say angiographies are being done repeatedly, it's like, it's like how they just do it when someone comes for a chest pain. So if you get something like this, like then how do you proceed? What do you do for that?
See that's very valid question, Dr. Geeta. We need to identify the provider behavior and the physician behavior. So, what kind of investigations are being carried out thoroughly from this physician or from the provider? As mentioned, rightly mentioned, for the endoscopies or colonoscopies, again, here it goes before going to the cost containment. Here it goes to the clinical presentations and the clinical outcomes and the clinical and the clinical treatment has been provided. We do have checks as a pre-authorization, which is actually the main job of a pre-authorization, to identify and to validate whether the right set of care has been provided before receiving the request or before requesting of this endoscopy or colonoscopy, whether all the labs are justifying the admission or the service. So yes, we do across such kind of request. Uh, we do across, like say for example spine surgeries where the patient has only mild back pain. MRIs are showing mild degenerations, but the surgeons are recommending for the surgery. So here the level of intervention appears disappropriate to the documented findings. So here, yes, we need to do the medical review and medical intervention, and then itself we can save the cost as well as we can enhance the better patient experience also.
All right. Thank you so much, Dr. Sakib. Okay, Dr. Arjun, now my next question is for you. See, as we all know, it's an era of technology and AI is often discussed as a tool for faster claim processing. But its real value may be in detecting the avoidable cost leakage before it becomes a paid claim. So now from a claims medical audit perspective, how can AI help identify patterns of overutilization, some coding inconsistencies, tariff deviations, fraud-based abuse, unnecessary investigations, and how should insurers convert those insights into practical cost containment actions without compromising clinical fairness?
So, Dr. Geeta, AI is an exciting topic. It's definitely very extensive and exciting as it is. But the closer you get, there are many things that's important we need to know that's missing out there. But equally, so is it capable, and so it has evolved so fast in the past year or so. Really, there's one thing which reminds me to, before I start with answering your question, that was taught to me by my leadership, or the mentor, I would say, is that we should drive AI and AI should not drive us. So as equally as AI is good and exciting, you get the best of it when you start driving it, not when you start allowing it to drive you. So,
Exactly. Yes, right.
so really, yes, we have Claude and ChatGPT and open source AIs and so many AIs. Perplexity, for example, it's a combination of multiple different AIs, and it can inherit and do different tasks at multi-level, combine all of it, and deliver something which no other tools can deliver to that extent, or you will have to use extent of a combination of tools to get your data replicated. So really, yes, when you stage the AI in a way that you drive it in a structured manner, it's going to give you the best results. The most important thing is that it misses validation. In terms, you have to validate whatever data or results that you get from AI. To make sure that yes, it is what you need. And this means the best way to validate AI is that you take it in stages. You don't put all the comments in one and then you got a report and then you don't know what it has done, right? So you take it through different stages and then you look at the report, you already know what has happened and you let AI do the work, but at the same time you validate it at every stage of it. So coming back to the question, so you had said that AI is often discussed as a tool for faster claim processing, but its real value may be in detecting avoidable cost leakage before it becomes a paid claim. That's so true. Now, the basis of AI is dumb data. The more structured, the more clean and more mapped the data is, the more valuable insights you get into the data. But at the same time, as the data grows, it becomes more complex. It can simply become incomplete or misleading, or it can be simply not aligned with the real operational requirement that you have. And this is purely because of the mapping. So it's really important how you simulate the data and simulate AI in this case. Again, as I said, the most critical stage is human validation at every point of it. In medical claims, again, there is so many different ways of auditing. When we talk about the real value of cost leakage, it comes down to how you monitor the behavior, because AI is a big tool. So which means the best of it is to really understand the behavior of the provider. So you create flags in it. You really cannot say that this flag is a recoverable flag or avoidable flag, but it's a flag that you can get into it. For example, let's take a provider who has more C-sections on the easiest way than other providers, than the median. So automatically, you know there is something going wrong here, right? And this is something which AI can validate and tell you, yes, there is something there, and it can flag it to you. Now, obviously, then you can deep dive and simply see, is it a primary provider or a secondary or a tertiary care provider? If it's tertiary care, it's obvious that you have referred all the complicated cases, and if all the complicated cases, you go into C-section as an option. But if it's a primary or secondary care, definitely there is a deviation from clinical guidance. You can jump into it. Then you can look into MRIs and PET scans. Let's say frequent MRI scans and frequent PET scans. For example, traditionally we used to do PET scans once in 2 years, and now you do, let's say, 3 or 4 PET scans in a year. What is the value of these diagnostics? It's really when you want to change the treatment management itself, right? So that's a last resort diagnostic, and if you're using it this frequently, there's something wrong. This is where AI can get in, because you will be feeding it with guidelines, you'll be feeding it with data that is required, and then you'll be mapping all these two together to understand really what is the trend. It flags. It doesn't say evidently this is what went wrong. This is where you have to validate it manually. So yes, in terms of behavior, provider scoring, it's amazing tool. Utilization behaviors, outlier reviews. It can simply, it's an automatic machine which can do everything in one second. So just going back to the cycle itself, today providers use AI. Where do they use? So you have all the TPS systems, or the major TPS systems in UAE are built on an open source mapping system of ICD and CPTs, which is Galen. So here you put an ICD, you already know before putting what, for this particular ICD, what are the medicines that you'll get approved and what are the CPTs that is going to get approved. This is through the open source mapping. Now in automation, obviously you have few rules that restricts this in addition steps, but for most providers who have AI enabled or automation enabled, they already know putting this combination of primary and secondary diagnosis, you will be able to get secure approvals for so-and-so CPT and so-and-so medication. So you're already interconnected into a revenue cycle system from your consultation, labs to pharmacy. You already book your revenue in that encounter. So this is from the provider. This is how advanced providers are. Why I brought this provider topic up is because as a payer, if you want to know how you're going to use AI in FWA, you really need to know what is happening at the ground level from the provider, which is the primary source. Then you have TPS systems. TPS systems are not AI enabled, although they are evolving into AI, but they're more of automation. So now here at this level, they're simply using Galen mapping and automation against the mapping. So it's already preset rules, which AI has already studied and submitted security approvals. And now it has come to us, to the payer. Now, can we really sit and audit these rules that has happened? No. So we try to analyze the born trends that providers are using quarter to quarter, month to month. What are the practices that have changed? So you suddenly have a new physician popping up, changing the billing in Abu Dhabi, E&M codes, how he's billing consultation, and how he's billing follow-ups. And what is the changes, what is the differences? This is something we can populate into AI, get the flags up instead of buying expensive dashboards. And with this, having said, a validation stage can be done. And from there, you will have an evidence to go and recover or stop from from payment, which is a prepay audits. But that's how far, as of today, AI has evolved. Yes, it has, for what it was nothing to what it is today, it is very advanced. These are things which normal softwares or rules-based softwares couldn't do, and AI is capable of doing it. Which means it is going to evolve drastically. But from a paid perspective, it gives an insight of network pricing, because you have the claims data enabled to you. And then you have the benefit mapping, then you have the benefit level burning, then you have the actual burnings. Then you also can easily calculate the severity index, which you can do it manually also, which is the traditional way and the right way of doing it. But AI can populate all this together and give you a better interpretation to the behavior of it as a more high level flags as of data. This is really how AI can do, and this is how your FWA has evolved as of today compared to what it traditionally was. So this is as far as what AI goes.
That was really wonderful, very insightful, Dr. Arjun. And a reality check as far as the providers are concerned, because I'm sure majority of the people over here, the audience is from the insurance background. So it was a reality check for them to understand what's happening and how the system actually cannot understand if this has to be denied. Because the rules that we set in, for the coding, and of course, this medical diagnosis is related to this particular lab or whatever. So it will just get passed away. It was excellent. Now, because rather coming to Dr. Sakya, because I know it's approvals and OPD approvals are too much, and of course now Dr. Arjun has already informed what providers are doing. So now, like from the insurance perspective, what do you think? How our system should be, how insurance system should be, so that of course it can find out those things and can avoid any kind of let's say over approval, or it can basically curtail the. I will not say fraud. It can be a fraud, but definitely abuse.
Uh, Dr. Arjun has given a quite a brief regarding the AI, the benefits and all. And yes, there is no doubt that AI has become the one of the most important part in healthcare operations. Uh, but as per my understanding, AI should be viewed as an augmentation tool to amplify the intelligence, but not as a decision maker. As Dr. Arjun also discussed and mentioned this thing, we should not, it should not be a replacement of a clinical accountability. It should work, it, as we always says, work smarter than harder. So AI should assist us, assist as a healthcare professional, as a TPA, as a peer, to work smarter, not harder, but it should not replace as a clinical assistance, a clinical judgment. So what AI can add, AI can add assist us uh, to make the data concise, to make the review and data extraction more okay, to identify what are the medical necessity by extracting key clinical informations, by comparing the request against the predefined clinical guidelines and policies as a pair, to identify the fraud and abuse by identifying the unusual utilization pattern, to identify the high risk, you can say, high risk scenarios. And also AI can help us to prioritize of prioritizing the workflow by tracking such straightforward request. But whenever it comes to a real clinical scenario where only the proper physician intervention is needed, so AI should give a red flag and should provide us the to review, I mean, forward those cases for the senior reviews. So AI can help as a pair, as a TPA, in the pre-authorization a lot. It can, but again, as per my experience, the human medical judgment must remain non-negotiable when it comes to dealing with the complex cases, to the ethics, to incomplete information when if the provider is providing. So AI can identify those things, but AI cannot provide the decisions based on those incomplete information. So situations where the clinical expertise are rare conditions, are rare diseases, they come in. So yes, AI is a very good tool, very good what you called assistance. But again, the future is not AI versus the healthcare physicians. It should work along with the physicians, with the TPAs, with the by implementing the AI software, we can reduce our work, and AI can increase our efficiency. AI can increase, make the consistency better. So it is a win-win situation. Like say for example, if I am being a payer, I'm at a pre-authorization, AI tool is reducing my time, is identifying more frauds, more no, I should not use the word fraud, inconsistency between the utilizations of the from the provider side by the repeating investigations. So AI can help in such way, and it can so our decisions making you can say our decision making authority will be more good, more efficient, and with the more beneficial for the patient, and also the patient will be more happy.
Agreed. Agree 100%, Dr. Saqib. That definitely AI cannot replace the human intervention, but definitely it can make us more efficient by reducing the time, by reducing the leakages, which actually can help a lot in the cost containment. Because that is the objective, ultimately that we want the proper care has to be given. And of course, the leakage has to be stopped because ultimately we are helping the patients, if you see. We are not letting their limit just go like that in the abuse and all those things. So, yes, thank you so much for your nice enlightening words. Now, my next question is for both of you. The question is that cost containment is no longer a financial discussion. It's now a clinical, operational, technological, and member experience discussion. So, if you had to recommend one practical change that insurers, TPAs, brokers, and HR teams should implement in the next coming 6 months to reduce claims cost without damaging the member trust, what do you think it would be? So, yes, Dr. Arjun, what do you think it would be?
So when we say cost containment, it shouldn't be that again we are saving money at benefit of someone. It's not like that at all. There's two parts of it from an insurance perspective. I truly believe affordability is very important. Yes, in today's day and age where R&D has evolved to a greater extent, this also comes with a cost. But then when you go for the most advanced or a very expensive equipment, when it's not affordable, it's also factually right that not many have tested it, which means the prognosis or the benefits of using it is not well established. Having said that, when you have an affordable treatment approach, you already know that the exposure of this treatment is to a higher multitude of people or patients, which means you know outcomes, you know the nature, you know how it is simulated in different crowd and different age, and you already know what to expect out of it. So I always say that affordable treatments are the best because it's tried and tested at its best. The new or expensive ones are good, but they are to be escalated to a crowd which is not working out with the traditional pathways. So it's a different journey altogether. Now, having said that, yes, coming back to your question, um, you have to unify the customer journey model supported by clinical governance. It's really important because now when we talk about insurance, it's not about I bought an insurance product today and tomorrow I'm just going to go and hunt myself another product in the market. Or go for shopping in the market, because it doesn't work like that. You still have a lot of negatives more than the benefits about it. Rather, I would look from a renewal perspective, which is more sustainable. So when I talk about cost containment, it becomes it doesn't simply become a sole responsibility of payer, but rather the HR, the member, because simply when you contain the utilization in the right way, but not compromising the treatment, but or restricting the benefit to the member, but simply through other pathways or optimizing the care journey, you save yourself in the renewal with the same policy without significant hike in the premiums. which means you have the same insurance, continuity of service, continuity of your care journey, undisrupted services, and something that you're already accustomed to do, and you know what to expect. So overall, your benefit to stay with the same insurer is more than switching insurers or simply going. It's another whole hassle to go into the market and look for another policy or another product, right? So it really becomes an approach of proactive utilization governance rather than a reactive claims control, where at the end you wake up and then think, wish I didn't use so much of my premium policy. Today my premium at renewal will be much better, right? So yes, the next 6 months, if you ask me what would be the plan, is that the insurers and the TPs should jointly monitor key utilization and cost drivers, come to a solution on how we can contain them, give a better accessibility of care to members, a right care pathway, and a right level of service, and live up to the promises we make. So that's it. Because simply, if you start not taking the measures, you will default yourself in future by not delivering the promises because your hands are tied by then. Now, if you are proactive, then being reactive, your hands are open to all the support you can deliver to the member.
Thanks, Dr. Arjun. Okay, Dr. Saki, we would like to hear from you now. What one practical change, what that change can be, which can be implemented in the next 6 months?
See, I second Dr. Arjun over here, was his thought. See, today, what are the main disagreement arises between the providers, payers, and TPS? This is the same, and why the utilizations are being high. So because every sorry, so they are often operate with the different expectations regarding the appropriate care. So and also so the utilizations are being high. Everyone is jumping from here to there, not on a standardized medical care treatment, but also to a different type of set of medical treatment. So what if I have to recommend one particular initiative, like what should be there in the next 6 months? So it should be a common unified evidence-based clinical pathway. It should be in the similar way across all the this one what you called healthcare system, because and also to early detection of the everyone should work on the early detection of the of the patient high risk cases. So if we will, as Dr. Arjun also was talking about the premium and utilization, if collectively, accumulatively, we will come to a common conclusion of the clinical pathway in such a way, like, okay, we can make a standardized medical criteria for the care where we can early intervene for the high risk cases. We can early detect those conditions. We can reduce our utilization. And also with assistance, since our topic was AI assistance, so AI can also help us play a crucial role in this category to identify such high risk patients by age, by category, by gender, by race, and they can AI can help us to minimize the data and to shorten the data in a way where we can implement our guidelines prehand, where we always say as a physician, prevention is better than cure. We can start preventing to control the future utilization. So we need to look into the evidence-based medicine, unified evidence-based medicine, where we can come to a common conclusion, and then we can enhance our efficiencies, and we can reduce the cost. And rightly in the beginning, Dr. Arjun said the cost containment is not about to restricting the amount at the care. We should not think only in this way, like we have to spend less, or we have to cut the cost. We should focus more on spending wisely rather than reducing the cost. So if we are providing the right care at the right time in the right setting, so both clinical outcomes as well as the cost outcome, it will be positive.
That was really impressive, Dr. Sakib. Really, very nice. And thank you so much to both of you, Dr. Arjun and yourself, for this valuable insights and experience. It was undoubtedly a very engaging discussion, and I'm sure our audience has taken away many practical ideas and perspectives. So, with that, I will hand over to Ankit now. Over to you, Ankit, for the question and answer sessions.
Thank you. Thank you, Dr. Geeta, and thank you, Dr. Arjun, Dr. Sakib. It was really, really informational. We will now move to the last segment, which is a question answer round for our audiences. So I would request everybody who is listening to us, if they have any questions related to the topic, they can put it in the chat box, and I can take as many questions as the time allows. We already have a number of questions with us. I'll just quickly start. There is one from Nitin Kumar from Care AI Tech. His question is directed to Dr. Arjun. He says, "Hi, Dr. Arjun. You mentioned using AI tools such as open source models and platforms like Perplexity to support claims review. From a healthcare data privacy and compliance perspective, how do you ensure that sensitive patient and claims data is not compromised?" I think it's one of the valid questions, of course, Dr. Arjun. Yeah,
I think
would
it's
you
a
like to
very
answer?
strong question, and given where we stand and the current regulatory rules, it's very important because all the organizations in UAE sits under, or healthcare organization sits under DOH, DHA health data regulations, and government ethics, and we have frequent intensive audits looking into these things if you're breaching. And the penalties for breaching is very aggressive, but this is all to secure the public tools and consumer rights, correct? So yes, the question is very valid. Now going back to how DOH, DH, and ADDIX operates is simply that they want all sides of patient data to be managed with highest confidentiality and at every stage. So yes, it is a very valid question, to be honest. And it's true that AI can breach this at multiple levels. And I think this has been the argumentative comment in the regulatory as well. To what extent can we use AI and how do we use AI, even though these discussions have not closed. So what I would, I mean, it's a tough question. So see, you are not, you shouldn't be exposing the patient data to AI. So again, it comes back to what I said. The website. So in some organizations, we have something called DNP restrictions, which does not allow you to feed AI with a document or a very confidential data of patient, and this has multiple levels of restriction, which means you can't copy paste details of patients. Simply, the website will get blocked and crash. And this is very important. So AI tools can be used by us in corporates, given they are within the regulatory governance. An IT team knows exactly what are the requirements from the ADDIX side. And these DNP settings from the clinical governance perspective can be enforced into AI, which means you can still use AI to the point where you would want a better intelligence, but not to drive decisions. So yes, you end up going to the point of taking a decision when you have the patient information to its core, correct? Or for example, let's say take a case, patient ABC has a policy to buy basic and has pancreatitis. What should I do with the claim? This is every information that can go wrong as a breach in terms of addicts. Same way, another question, rephrase to AI. Patient has pancreatitis, what could be the etiology, and go into other different questions based on the condition. Now you're not in breach of addicts. So DNP settings, in terms of how it monitors and allows you to put this information into AI, restricts you to what it can feed, and this is already aligned with the regulatory governance. And yes, many major organizations have it, and it's something that every organization has to implement as a rule, which aligns you with the regulatory frameworks. I think Nitin also has a question in continuation to that. Would it be more appropriate to deploy these AI models with a secure enterprise environment? Yes, there are secure enterprise environments, which, for example, major TPAs today are collaborating with AIs. And yes, they are very secure. They don't feed the patient information itself into the AI module or don't give the exposure to that, or the AI module itself is very secured, ring fenced. All these data so these ethics requirements regulates where the data is stored, how it's shared, and to different levels on how it's operated. So these corporate settings are mandatory and they're regulated by the government, and this is what secures the use of AI in the best possible environment, to use its intelligence but not to make it a decision maker and not for it to breach the ethics requirement.
Right, right, Dr. Arjun. Thank you so much. Yeah, I mean, AI in itself is a very, it's not a very straight line topic to discuss upon because there are a lot of legalities involved and a lot of complexities involved as well. But I hope Nitin has got his answer. Okay, I have one question for Dr. Saqib. Priyanka Nayak is writing, Hi, Dr. Saqib. Could you please suggest any reliable websites, accreditation bodies that can be used to verify providers, hospitals, when we identify discrepancies between the treatment recommended by a hospital and the medical document submitted by the client?
Okay, thank you.
Yes.
So, for the bodies, if we'll talk about this website, so there are different kind of websites which are evidence-based clinical references where we used to follow. Like, say for example, for oncology, we are following NCCN guidelines. Okay, if you are talking about the UK based, so we are using the NICE guidelines. We are using ACC, AHA for the American guidelines. So actually, different countries are using their own regulatory bodies. So in UAE, we are also following the DHA guidelines, DOH guidelines. But for the clinical, if you are talking about the clinical suggestion, like where we can get the best one of the best one, I will not say the best, but one of the best is up to date. Please follow up to date. You will get all the updated clinical guidelines which are unified, which are across all the world where they are being followed. So from my side, the best recommendation which I am using also from past 14 years, you can say my team is using, my previous organizations they were using, that's the up to date. And for the oncology, we are using the NICE and NCCN guideline. I hope it will help.
Yes, yes. Thank you, Dr. Saqib. I think Priyanka has got her answer. We have another one which says, Hi, Dr. Arjun. If autoimmune and cancer cases are referred to home country, which may require a long-term treatment, how will it benefit an expat? This is from Care Link.
Definitely. So when it comes to autoimmune diseases, your ultimate treatment plan goes down to biologics. Biologics are very expensive. This becomes a question to almost all the patients who go through the autoimmune conditions, because yes, biologics have evolved so much that your the lifestyle or how you live becomes almost normal to a normal being. For example, take a simple condition as psoriasis. It can really make it so hard for a patient to go through that. Of course, no disease is good, and by God's will, no one should go through anything as such. But then, yes, these are conditions which exist, and when people go through it, it's really difficult. Sometimes, for a good number of patients in these conditions, biologics become an ultimate treatment. To the point you become normal completely in terms of everything, how you feel and the metabolisms and the body functions, everything become normal when you use biologic. It has benefited so many people. Now, the cost part of it, it's a burden. It's not affordable. When you choose home countries or when you choose different countries as an option, you have options of biosimilars, because now you should understand that every country is heavily regulated when it comes to pharma. Pharma industry is massive. In terms of R&D, in terms of the regulatories, for example, you have a medicine which is FDA labeled and the same medicine has a non-FDA label. The two different cost proportions to both assigned is very different. Simply an FDA label can cost you anything. I'm using dirhams as a median, and it could simply cost between 60 to 70,000 dirham versus a non-FDA at 30 to 40,000 dirham. So you can already see the difference. Now, in addition, let's step into biosimilars. Now, again, you will be going down all the way to 5 and 10,000 dirham. So a treatment which could have been availed at 70,000, which is the FDA label, you go down to a non-FDA label, and then you go into biosimilar. Again, you really go into an affordable segment of treatment curve. Now, these treatments includes a lot of investigations, routine investigations on how you use the medication, monitoring, which makes it in total an expensive ordeal. So really, home country, for example, the Asian countries where there is no much, I mean, there is a significant FDA influence, but at the same time, these countries regulatory supports in R&D, which allows for biosimilars or in-home, in-country grown medications. It makes it more affordable when you have the same components, same mechanisms, almost same outcomes. Yes, this is an arguable point. Sometimes you can say the FDA label has a higher outcome and this one lower. But at the end, is the objective met? You are treated. Yes, you are treated. So yes, and again, you're treated in a more affordable aspect. Which means you have not compromised. What is the point of me taking a 70,000 dirham treatment with one dose, and then I'm not able to afford the rest of it? I never see the light at the end of the tunnel. So again, on the contrary, I take a more affordable treatment and I go through the whole journey of it at a fraction of a single dose cost. And then I see the real outcomes of it. So the whole, again, coming back to it, affordability is key, and an affordable treatment is always at its best because it's tried, tested, and used by everyone. So you know how it functions. And the fact that it's affordable makes it simply the best.
Right. Correct. I think I'll just take two more last questions, one to Dr. Saqib and then Dr. Arjun again, because I think we are already ahead of our schedule. So, Dr. Saqib, one question for you. Home country treatment shows significant savings, but how do you medically assess which cases are suitable to travel and which must be treated locally? This is Sushmita who is asking this.
Okay. For the home country, we need to understand, like, okay, first of all, as our main aim is to provide the best care in the cost efficient way. So that's why we are, and Dr. Arjun has already explained this in the for the home country. I will not go back to that explanation, where the patient can be at home, had a multidisciplinary care over there, and as well as along with the family, patient can have a more better progress, and also the cost saving. Now, how to choose those cases? We need to understand what type of here there is no pick and choose cases, to be very frank. Yes, any case which is elective, where there is no risk to the patient care, but yes, there is a multidisciplinary care, family, emotions, everything is all together, and cost saving is there. We can choose that. So, but my suggestion to pick and choose for the home country care, any elective request, where the progress of the condition post surgery requires time, that should be chosen, as well as cancer cases, oncology cases specifically, where we can provide the better care support as well as the emotional support, psychological support to the patient. We need to choose that.
Right. Very well said. I mean, when we talk about home commentary, I think most of the people who are not so educated, they look for cost containment only, but it also the family support and emotional support for such specific, long-term treatment diseases. Very well said, Dr. Saqib. And the last question, I think I will take it for Dr. Arjun. It's a long one, so I'll just read it out for you, Dr. Arjun. Autoimmune diseases treated with biological therapies require continuous clinical monitoring, regular investigations, periodic dose adjustments to ensure that treatment is effective and patient is safe. While procuring the medication from outside the country may potentially reduce the drug acquisition cost, yes, it can create challenges in ongoing treatment management. Any required dosage modification based on clinical response or laboratory results may necessitate additional consultations, obviously monitoring, medications, adjustment resulting in Okay, delays in memory. Okay, so I don't see the question here, but I think the question is, how do you tackle such things when you are getting medicines from outside, which require a lot of time, as well as extra, tests and everything. So I think this is what Shagufta is trying to ask.
Okay, so
Yeah.
basically, if it is towards cross-border controls or if it is about a supply chain, again, these are two different things. But let me explain how, if it's about supply chains.
Mhm.
Definitely, again, I'm confused on the question, if it's okay.
Yeah, so I think she's trying to ask is if we get the high dose drugs from outside, obviously it'll take time and it requires it can create challenges in ongoing treatment.
True.
So yeah, and so how do you tackle it as in resulting in? I mean, first of all, do you support such things? I mean, getting procurement of medicines from outside,
We don't.
does it really affect the treatment or yeah?
No, honestly, it comes to clinical governance in multiple levels, and there's a lot of regulatory control once again when it comes to cross-border biologics or any high-cost medications or medications which are logistic controlled, for example, temperature control, time sensitivity, and these medicines have a very different mechanism of transport on its own. Normally, hospitals have this option when there is no availability of a medication, in particular to what is required to treat the disease in UAE, to do the procurement through the right procurement channels, through suppliers, and these are all
Right.
regulated heavily by the government, including the logistics. So it doesn't make it cheaper, by the way. To a point maybe, but it's not. I mean, you only go to this extent when you really need something which is not available. From cost saving perspective, if you're going to do it on your own, you might compromise the integrity of the medicine itself. So yes, I'm not sure how I can answer that question through a clinical governance perspective, but from the regulatory aspect or from a standard practice, do we as insurers encourage this practice? No, we don't. Now, it is on the contrary very different to the question or the discussion that's ongoing, which is a patient going to home country to avail a whole uh, course of treatment compared to procuring a medicine in UAE just to save medicine. Because if you're trying to procure a medicine from UAE to save the cost, it's not always the case because the logistics by itself is so expensive that it'll almost become the same cost unless and until you do something which is at your own risk. Again, when you do something at your own risk, it has its own consequences and its risk factors. As to the hospitals, they have an open channel, but again, it won't save cost in terms of procurement through supply chains.
All right. Yes, fair enough, Dr. Arjun. I think the question itself was a bit too long. But yes, I think that's it. We have more questions, but I think we are already, ahead of time, so I won't take much time. So we come to the end of this today's session. A heartfelt thank you to all our panelists, Dr. Saqib, Dr. Arjun, and of course, Dr. Geeta, for such a rich and practical discussion. If there is one message I hope you take away today for our audience is that it's the one we started with, that real cost containment is just not about saying save money only. It's about getting the right healthcare the very first time for the member and for the payer. Yeah. So thank you to your audience for joining us and your thoughtful questions, and a big thank you to the entire team behind this session. We'll be sharing a feedback link shortly to everybody who has joined. So we would love to hear your thoughts. You will also receive a YouTube link because you were live on YouTube. You can watch that webinar again if you have some doubts, and you can share it with your friends and colleagues. We'll be back with another engaging webinar soon. Until then, stay tuned, stay well, and have a wonderful day. I would not let you guys go without the final thoughts. We'll start with Dr. Saqib. Any final thoughts you want to end the webinar with to our audience, or maybe anything? Yes.
So thank you. I will talk from the pre-approval perspective. I will just want to make sure, like many people think, like the pre-authorizations, which we are doing the cost containment, and we are playing a delaying tactic. But actually, our goal is not to delay the medical care. Our goal is to make sure our members, our patients are getting the right treatment in a cost effective way and we need to make the balance. It's not about like, okay, savings. It's about the balance and the right care for the right person at the right time, to avoid any unnecessarily or inappropriate care. Because it's not only about, again, I'm telling again and again, it's not about saving money. It's about what is the best, because if incorrect investigations, incorrect or unnecessarily treatment is being rendered, it is a health risk, not only the cost risk. So we at a pre-approval level, we are a gatekeeper and we are trying to safeguard your money and your health. So it is not about cost saving only. Cost saving is only a small factor. Thank you.
Yes, very well said. I think this was a question from one of the audience as well, but you answered it right here. Absolutely, I agree. And also it is the first checkpoint actually for, for a payer, for insurance, for a medical team, in fact. So yes, Dr. Sabi, thank you so much. Dr. Arjun, over to you. Any last
No, to be honest,
comments?
to be aligned with the leadership of this country, I think they have enforced and cascaded their vision that patient comes first always, and given to central bank that regulates the financial institutions, and DOH and DHA, they all step up saying patient comes first, and this really becomes our intention, and this is really how the policies are designed with the regulatory framework. So cost containment is not really to save money, but to really enhance and prolong your care journey, to better provide you with something which is of more valuable, and which is more proven and more tested. So again, that's what I would say.
Absolutely, absolutely. And I think, talk about, at Prospera with Dr. Geeta and Nancy as well, that we are working very closely with insurance companies and other TPAs as well. So it is very important for us also to understand the whole concept and, guide our audiences and our customers as well. So thank you so much. Dr. Geeta, anything from you, Nancy, and then we end. Yeah.
I think thank you so
this
much,
was very
Dr.
amazing.
Sakib and Dr. Arjun, for such an informative session and taking out time for this session. It was really, really helpful. Thank you once again. Over to you, Dr. Geeta.
Yeah, my sincere thanks to both Dr. Arjun, Dr. Sakib, and of course, definitely to the entire audience. They were all with us, and yes, so thanks to all. And I agree with what both of them have said. Cost containment is not to save money, it's to make the insurance more sustainable for them, because it should be
Absolutely.
used at the right time in a proper way. So that's it.
Absolutely. Yes.
Absolutely. All right. So at that note, we end the webinar session. Thank you, all of you, and have a
Thank
wonderful
you,
day
everyone.
ahead.
All
Thank
right,
you.
Thank you.
Thanks.
Thank you,
Bye.
Ankit. Thank you, Nancy. Thank you, Dr. Geeta. Thank you, Dr. Arjun.
Thank
Thank
you.
you.
Thanks.
Thanks.
Bye.
Bye.
Thank you.